Okay, so I would start this case. This is 63 years old male and recent onset of syncope. It's really atypical, but it's very recent onset. So what do you think of this left main? It's not super clear, but compared to the proximal portion, it's narrow and some hedginess, right? So we did the IVAS. This is from the LED and trifurcation. This is the left main, looks very stenotic, a lot of plaque, and one more time, trifurcation. Distal left main, very stenotic. You see something on the top of the plaque, and here I see dark area. Last time, this is trifurcation. Come to the left main, stenotic. Here, looks like the low intensity area. So this is actually very dangerous IVAS. When you look into all together, this is really talking the ACS-related morphology. Number one, left main is very significant. Number two, I see something on the top of the plaque. This I diagnosed, this is organized thrombus on the plaque. Deep side, I see like the ruptured cavity. So altogether, it seems to be this is recent rupture and thrombus on the top, and then acute stenosis progression and causing this type of the symptom. And LAD ostium was very significant, and circumostium is very significant, and altogether, if we didn't diagnose at this point, and patient may suddenly die, this is really acute onset of type of the plaque. After discussion with the patient, and we decided to go to the PCI, and after crossover and curate stenting, you see the nice result. And this is truly how it looks like the left main bifurcation caliber. The ostial left main is big, and distal left main is also big. And remember first time, it's very narrow. This is the final result. Everywhere looks good. So the next one, this is also very important for the left main, and especially I would emphasize of the young interventional cardiologist. Whenever you see this type of the left main, I really recommend to check the imaging. So this is 60-year-old female, and she's going to be the liver transplant, and this is before the transplant coronary evaluation. When you look into the left main, you think this is very critical. We have to check the IVAS. This is IVAS pullback from the circumflex. It's really big, not much disease. This is OM, and this is still proximal circ, and that's a LED, and this is huge distal left main. We come back to the ostium, now getting narrow, that's ostium, and then connected to the outer. One more time, circumflex, it's okay, OM, it's huge proximal circumflex. LED is coming in, this is distal left main, it's huge, and then coming back more proximally, you see this is ostial left main, and then connected to the outer. So when we look into the IVAS, this is really not significant, but why we feel this is such significant is because we look into this diameter. This is a left main, it's very oval shape, this is diameter, and this is distal, and because of this, we feel this is like 50% diameter stenosis. But this type of the left main sometimes happen, so really have to check by intravascular imaging. So the next one is more likely critical case. And this patient is 82 and severe AS. And finally, with discussion, we decided the PCI and TAVR. And this is before TAVR in the left main PCI. But when we look into this distal left main, it's very unclear where to where in terms of the disease distribution. And we did IVAS 3 round related to the left main and circumflex left main as well as LEMAS. The first picture is LED to the left main. Number one, left main is quite significant. You see the lumen is 4.1 square. And LED looks significant as well. Overall calcium was not too bad. None of the place is more than 180 degree. That's a good information. And proximal LED is media to media is 3.6. This is distal to the big diad. And left main is 4.8. So once we know all information, we decided to put a stent from here to the left main, 3.5 up to 4.5. That's very clear. We move to the circ, And I do think this is okay. Many people may choose the provisional, but this time operator choose the two-stent technique. That's okay too. This is osteocirc. And circumflex caliber is also very important. You see the big OM. And distal to the OM, vessel size is much smaller, but when we come to the proximal to the OM, vessel is much larger, and both are normal. So when you see this type of picture, we decide, let's put the stent from the here to the left main, and then we can use the 3-5 stent. Those decision is very important. And when we move to the limas, we see the limas ostium is very clean, and finally, this very complex trifurcation region seems to be very clear. Distal left main region up to the LAD, and we see the 3.5, 4.5, all planning was done based on the 3 IVUS. And because of this, we go ahead to treat, and first non-compliant to the SARC, non-compliant to the LAD, and then stenting in the SARC to the left main. Be sure the stent has to be proximal to the OM to be able to use 3-5 stent. Therefore, we did a port for the left main, open up to the LAD, and then we put the stent into the LAD to the left main, and the port into the left main, and then 1-to-1 kissing balloon, and then finally port. All of the procedure was planned at the beginning, once we see the entire IVUS. And then finally, we confirm each segment. This is the LAD to the left main. The smallest area, the left main is huge, and the LAD is also good. And then go to the circumflex, we confirm stent was not extended to the distal to the OM, it's good. So those are the whole process. What is the most important is the planning at the beginning. This is a final picture, and we are quite happy. So those are the typical type of the left main and the planning. But this is kind of the exception. So I'm going to show how to deal with this type of the cases. This is an 81 years old female, and you see the stenosis in the osteal LAD and proximal segment. But in terms of the left main, we are not very sure how much disease and circumflex as well. Angiographically, looks okay. We did the IVUS in the LAD to the left main, and number one, left main is significant based on the 6 square criteria, and the proximal LAD looks like calcified nodule. That's quite significant. But overall together, the calcium, not bad. It's overall together, the calcium was bad. It's circumferential calcium and the calcified nodule, and we elected to do the shockwave for the LAD. That's LAD. And moving to the SARC, and that's actually most surprise. When we look into the SARC, angiographically it's okay, but when we look into the SARC, it's circumferential calcium as well as very narrowing. And we decide we have to treat the circumflex, but how to do it? And then first, let's try to the shockwave into the SARC as well. And this is also calcified nodule. And then, because of this, we go to the shockwave into the SARC and the LAD and the left main. Afterwards, this is a picture of the SARC, and we again surprise. You see the circumferential calcium is nicely fractured. You see the 2 different fracture, and lumen is large. And we consider this circumflex is actually controlled fracture or controlled dissection. It's not flow limiting, it's not like the big dissection. So we thought this is a good outcome, we should not stent, because seems to be this is a good result. And we thought additionally, this is a different case. When you treat the LAD to the left main, many times you see so-called carina shift. What this meaning is circumflex ostium at the beginning was very normal, and you see the no plaque at all. After the stenting from the LAD to the left main, you see the circumflex carina is moving to the circumflex side, meaning this is a LAD. LAD is pushing to the osteal circ, and you see the circumflex ostium is over, and because we're looking this way, we see the circumflex very narrow. But many times, this type of the carina shift doesn't causing the ischemia, and it's okay. But when this happens, is typically if the circumflex is quite normal. So considering this pattern, we thought that circumflex is okay, because almost like natural stent based on the calcium. Additionally, somebody may feel the plaque shift. Typically, plaque shift occurs if there is a chunk of the plaque in the left domain. Like this, you see the ulceration and chunk of the lipidic plaque. After the crossover stenting, this plaque moving to the circumflex ostium, that's we consider the plaque shift. We didn't think that's also occur because circumflex was very calcified, left domain as well. And then, in terms of the circumflex, our case is really natural stent, and we did already control the dissection or fracture, and then we don't think that's carina shift because they already did it, and we don't think plaque shift because of the left domain is very calcified. And then we just go ahead to stent into the LAD to the left domain after the port. This is final result from the LAD to the left domain. You see the LAD in the left domain is nicely open because we prepare very well. And finally, this is the final picture. And even we didn't do the IVUS into the circ, even we didn't wire to the circ, because we are very confident circumflex was very controlled calcium fracture, and you see the nice chemistry flow and we'll open the circumflex. And sometimes this kind of way is saving the good procedure. So we thought that's one way to do so. The last one is also kind of surprise. This is a patient, 92 years old male, and moderate age. And everybody saw this patient of the chunk of the calcium. I thought so. And when we look into the angio, I thought this is definitely calcified nodule. It's really tight, and suspicious is a lot of calcium. And we did the IVUS first. This is IVUS pullback from the LAD. And coming to the left domain, this is the left domain. And what did you see? This left domain is actually not too bad. Coming back, this is the left domain. This calcium is really not too bad and quite focal. Additionally, this is quite interesting feature of the circumflex ostium. I'm going to show one more time. Here, you see some kind of funny shape, which actually we are looking at the aneurysmal appearance of the ostial circ, meaning this is the aneurysmal appearance of the circ. Actually, this is a good sign because when we cross over to the aneurysm, it's very unlikely having the issue of the circumflex. Number one, that's one. And number two is the left domain was significant, but that left domain calcium was not too bad. This is a really good surprise compared to the angio and patient background. And because of this picture, we thought this is really good, just balloon and stent, no problem, because this is not about calcium. And we did. And first, we did the balloon into the left domain, crossover to the LH to the left domain, and port. That's it. And this is afterwards. You see the LH to the left domain. It's well open. And in terms of the circumflex, you see kind of aneurysmal appearance that's opening well. At the end, this is a final picture. You see the circumflex ostium is nicely open. And we are quite happy. Even we didn't kiss because we're confident the circumflex is fine. So there is a multiple pattern, but I do think what is important from the beginning to evaluate entire disease and vessel size is the most important for the left domain PCI. And what is most important is good planning at the very beginning. We did the multiple runs, spending time at the first time, and then decide how to do at the very beginning. How to size and how to balloon, we decide everything at the beginning. So good planning, especially the circumflex planning, is the most important. However, when we do the IVUS or OCT, sometimes we see the surprise. I show, like we thought that's very severe calcium, but actually it's not. Or we thought it's calcified nodule, it's not. And we thought we don't have to treat the circumflex, it's not. But finally we decide that's kind of control calcium fracture, making much better for the circumflex, and we leave it alone. So there is a multiple consideration, but I think from the beginning to see entire disease process is the most important. Thank you very much.